Last time I talked about vertebrobasilar insufficiency as central vertigo, HVBI, from the brain, which is a common outpatient disease. In this article, I will explain central paroxysmal positional vertigo. The concept of central paroxysmal positional vertigo was covered in the first slide of 4:1. So, I will describe it again. In a broad sense, paroxysmal positional vertigo can be classified into three categories. 1. Benign paroxysmal positional vertigo, BPPV. 2. Central paroxysmal positional vertigo, CPPV. 3. Malignant paroxysmal positional vertigo, MPPV. Benign paroxysmal positional vertigo is already well known, but the second type, central paroxysmal positional vertigo, is less well known even among doctors. As I mentioned in 4:1, central paroxysmal positional vertigo was first described by pseudotype, that is, pseudo-benign paroxysmal positional vertigo, which was proposed by the late German professor of neurology, Dr. Kornhuber. The name of this disease has not yet been formally defined by academic societies, so it is not well known in internal medicine as well as otolaryngology. I believe that there is a significant number of this central paroxysmal positional vertigo being mixed within the diagnosis of benign paroxysmal positional vertigo. Especially in internal medicine, I would like to comment that central paroxysmal positional vertigo is much more common among middle-aged and elderly patients with a background of lifestyle-related diseases and cervical spine abnormalities. In my 10 years of experience in otolaryngology, nystagmus can be reliably observed. Therefore, I have seen cases of central paroxysmal positional vertigo that might be diagnosed as benign paroxysmal positional vertigo, responding well to anti-herpes virus drugs. Including my experience at Yokosuka Kyosei Hospital, there have been about 40 cases in which anti-herpes virus drugs have been effective. This fact has not yet been reported by anyone else in the world. The theory that benign paroxysmal positional vertigo is mainly caused by otolith movement in the semicircular canal is now dominating the world. But if otoliths are the only cause, anti-herpes virus drugs should be ineffective. When I posted on YouTube that I had doubts about the otolith theory of benign paroxysmal positional vertigo before, the Vestibular Disorders Association of the UK commented, "We are interested in your thoughts. We too have doubts about the current otolith theory of benign paroxysmal positional vertigo." This comment made me feel encouraged that there are like-minded people in the UK. In the next case, the nystagmus appeared to be benign paroxysmal positional vertigo, but it was accompanied by loss of consciousness and blackout, so it was central vertigo. The patient was a 60-year-old female. She visited the hospital because of vertigo. She described that she was quite tired from working at the hospital and caring for her parents after returning home. During the interview, it is important to find out if she had brief loss of consciousness or blackout accompanying the vertigo at that time. So, if these symptoms are present, the cause of the vertigo can be determined to be central, namely from the brain, not the ears, at the interview stage. The nystagmus is directional alternating downward rotatory nystagmus, which, if judged by nystagmus alone, would indicate benign paroxysmal positional vertigo caused by the inner ear. However, loss of consciousness indicates ischemia in the upper part of the brainstem, and blackout suggests ischemia in the occipital lobe of the cerebrum. So these symptoms can rule out benign paroxysmal positional vertigo and lead to the diagnosis of central paroxysmal positional vertigo. Cervical MRA showed marked tortuosity and meandering of both vertebral arteries as shown in the figure on the right. Red arrows. When atherosclerosis appears, the lumen of the arteries not only becomes narrower, but also stretches in length like an old rubber band. And since the height of a person's neck is fixed, the arteries have no choice but to bend and meander. In other words, if tortuosity and meandering can be observed without opening the arteries, these findings indicate the presence of arteriosclerosis. When both vertebral arteries are found to be sclerotic, the brainstem naturally suffer from chronic ischemia usually, and subtle poor blood circulation occurs. Nevertheless, vertigo does not occur in this subtle stage of poor blood circulation. However, when mental or physical stress is added to this stage, as has already been proven in the U.S., the increase in stress hormones released from the adrenal glands activates platelets, which further excites the sympathetic plexus around the arteries, causing the arteries to contract. It is a well-known fact that when platelets are activated, blood flow becomes stagnant. This makes the ordinarily subtle blood circulation problem more severe, causing ischemia in the brainstem and cerebellum, which leads to nystagmus and vertigo. After all, the diagnosis is central paroxysmal positional vertigo from the brain via poor circulation in the vertebrobasilar artery, HVBI. In middle-aged and elderly patients with vertigo accompanied by blackout, especially those with diabetes or pre-diabetes, hypertension or dyslipidemia, there is a great possibility that arteriosclerosis is progressing. In this respect, unlike younger people who have no concerns about benign paroxysmal positional vertigo caused by otoliths, it is important for middle-aged and elderly patients who have such symptoms to review their daily diet and lifestyle as a countermeasure. It is unfortunate that the mainstream of the medical profession still believes that 60% or more of all vertigo cases are benign paroxysmal positional vertigo caused by otoliths. This case was seen vertigo and complained of symptoms of fading consciousness from the beginning. In addition to this, the interview revealed that there was also blackout. As a result, central vertigo from the brain was suspected before the medical examination. The patient is a 67-year-old male who works as a farmer. He came to the hospital with symptoms of vertigo and a feeling of loss of consciousness. The feeling of loss of consciousness can be described as pre-syncope. These symptoms alone can rule out ear-induced vertigo. Palpation revealed a strong stiffness in the back of the neck, posterior neck. Cervical spine X-ray showed deformity and a straight neck, which turned out to be the cause of the stiff neck and shoulders. The nystagmus was directional alternating downward horizontal nystagmus, which could have been diagnosed as benign paroxysmal positional vertigo at first sight. However, head and neck, MRA, revealed that the left vertebral artery was not only narrowed intracranially but also twisted twice, red arrows in the lower right figure. As I mentioned earlier, this finding suggests arteriosclerosis. The two twists slow the blood flow rate in the left vertebral artery, resulting in turbulent flow after the right and left vertebral arteries join the basilar artery. Then comes the usual subtle blood circulation problems in the brainstem. This stage does not yet lead to vertigo. When stiff neck, shoulders due to a straight neck and cervical deformity, in other words, strong tension in the cervical muscles are added to this condition, the sympathetic plexus surrounding the vertebral artery is excited, causing the vertebral artery to constrict more easily. In this situation, blood circulation in the brainstem, especially in the vestibular nucleus, becomes worse than usual. This then causes vertigo. In addition, ischemia in the upper part of the brainstem causes pre-syncope, and ischemia in the occipital lobe of the cerebrum leads to blackout. Based on these findings, the diagnosis in this case is not benign paroxysmal positional vertigo from the inner ear, but central paroxysmal positional vertigo from the brain via poor circulation of the vertebrobasilar artery, HVBI. Next, strong tortuosity and loop formation were seen at the origin of the vertebral artery where it branches off the subclavian artery and heads toward the brain. Namely, 2 cases of central paroxysmal positional vertigo through poor circulation of the vertebrobasilar artery, HVBI. The first case was a 71-year-old male who had vertigo when lying down on the back and changing the position of the head to the lower left or the lower right in bed, in other words, vertigo during head transfers. The nystagmus was the same as benign paroxysmal positional vertigo. The right vertebral artery was not clearly seen on MRA of the neck. It was thought that the right vertebral artery was congenitally narrower than the left one, and that the right vertebral artery had become narrower due to arteriosclerosis with advancing age, resulting in a considerable decrease in blood flow. Additionally, a strong bending was observed at the origin of the left vertebral artery, which usually maintains blood flow. With such a strong bend, the blood flow velocity in the vertebral artery decreases and the flow in the vertebrobasilar artery also slows down. The second case was a 67-year-old man who also had vertigo when his head was repositioned to the lower left or lower right while lying on the supine position. The nystagmus was the same as benign paroxysmal positional vertigo as in the first case. It is already known that the origin of the vertebral artery is a prone area to atherosclerosis. In this case, too, a loop formation was seen at the beginning of the vertebral artery due to arteriosclerosis. And with such changes in the arteries in both cases, it is natural that poor circulation must have occurred on a regular basis. In addition, originally the sympathetic plexus surrounding the vertebral artery origin is more densely distributed than in other parts of the vertebral artery, so if strong changes occur in the vertebral artery origin, the sympathetic plexus may be easily excited. But this stage does not immediately lead to vertigo. In this situation, a sudden change in the position of the head can trigger a worsening of blood circulation in the vertebrobasilar artery than usual, resulting in vertigo. Hence, the diagnosis in both cases is not benign paroxysmal positional vertigo caused by otoliths in the inner ear, but central paroxysmal positional vertigo from the brain mediated by poor circulation of the vertebrobasilar artery, HVBI. In the next session, I would like to describe several cases of stroke after an attack of central paroxysmal positional vertigo, which may be diagnosed as benign paroxysmal positional vertigo on the surface.